is another short but very interesting case. So this was a 40-year-old female who presented to us with complaints of drooping of both upper lids for 20 days duration, binocular horizontal diplopia for 20 days. There was no history of any diurnal variation of the ptosis. She did have a complaint of hoarseness of voice. Um, no other positive complaints she had. Visual acuity was 20/20, color vision was normal. The other anterior segment examination and fundus examination was essentially normal. So if you look at the 9-gaze picture here, she had an elevation limitation of -3 in both the eyes, depression of -1 limitation in both the eyes, and an abduction limitation of -1 in both eyes, and an adduction limitation of around -2 in both the eyes. So if you look at the vertical fissure height, it was 7 millimeters in both the eyes. And the other ptosis examination indicated that she had a good LPS action, and the bells in both eyes was good. Her fatigue test and ice pack test turned out to be positive. So we were wondering here what this could be possibly. Was this pathology of the extraocular muscles, or was it a lesion at the neuromuscular junction? So we thought of a provisional diagnosis of ocular myasthenia and went ahead and did a neostigmine test. So the neostigmine test revealed a worsening response, and so we kept the patient on a trial of pyridostigmine. She came to us a month later. There was no improvement in the extraocular motility or the ptosis. So she was also, the acetylcholine receptor antibody was initially sent. The reports weren't there with her, so we did also start her on oral steroids. And she came back to us and she had no response with pyridostigmine and oral steroids, and her serum acetylcholine receptor antibody was also negative. On further asking history, we did get to know that she was HIV positive and she was on ART. And we did follow her up. She was kept on pyridostigmine and steroids, but she did not have any improvement at all. So the sequence of events is like this. She presented to us with ptosis and external ophthalmoplegia. She was suspected to have ocular myasthenia gravis and started on pyridostigmine and oral steroids, but since there was no response, we were wondering what this could be. Was this really ocular myasthenia gravis, or was it something else? Possibly an ophthalmoparesis secondary to the antiretroviral therapy that she was taking. So this was an interesting report that was published where they have seen such scenario in patients receiving antiretroviral therapy. The interesting thing that they said was in the orbital MRI, there were patchy bright signals in the extraocular muscles with a preserved volume of the extraocular muscles. So that was something interesting that they showed up in all their patients. And these patients can also have red ragged fibers like we see in CPEO as well. So the take clinic message would be that long-term antiretroviral therapy can lead to ophthalmoparesis, and obviously it's imperative to rule out ocular myasthenia gravis and CPEO with appropriate investigations and history, obviously. Thank you.
Thank you. That yes. Although I would say that it is sometimes difficult for us to differentiate with CPEO, because that also has sometimes extremely variable presentation. So that is of course there, and so can just be that we are associating it by chance, but yeah, you also have a literature to support that idea. So difficult to confirm either way, but yes, it's an interesting thought to for us to remember that this could also present like this, and we may be in future picking up more cases as we are more aware of it. Thank you. A very interesting case. Thank you.